Good afternoon. And thank you for the introduction, Chair. And I'd like to thank at the outset the organizers of the All India Ophthalmic Society. With that, I start my talk. As introduced, I have worked in New Zealand. I'll show you an interesting photograph subsequently. I'll talk on clinical translation of ophthalmic genomic knowledge, and I have a couple of affiliation. I'll come to that at the end of my talk. So most people in Australia and New Zealand will recognize this photograph, and this is a traffic jam that you see in New Zealand most often, particularly where I lived in Dunedin in southern part of New Zealand. So you have hundreds of sheep that come against you when you try to maneuver yourself in the traffic. So in Dunedin, when I was working under Dr. Michael Denton, we actually identified about half a dozen retinal genes that causes degeneration, including RPE65. And this is my family with whom I stayed in Dunedin for about at least 5 or 6 years. Now, when you actually take the genomic knowledge and try to apply it to your patients, there are 4 ways by which you can help them, okay, particularly when you do a genetic test. So they come for you for genetic counseling, and where they at times need a clinical diagnosis where you might have missed a syndrome. And secondly, when you know the mutation, whether it is autosomal recessive or X-linked recessive, you know that the course of the disease will be very severe. So therefore, doing a genetic test helps a lot. The second situation in which they come to you is for premarital genetic counseling. So they have a family history, or they might be affected and therefore want to get married and want to see the options. Then the third category is preconceptional or prenatal genetic counseling. Again, the family history, they already have a child with the problem and they want to plan the next one. And the fourth, which is of interest in the last decade or so in India, is that there are a lot of interventions and research that is happening in the treatment aspect and management, which we did hear in some of the talks earlier in the session, including uveitis. So molecular therapy is coming in a big way. So let me go through 4 different situations that I mentioned, and I'll take few cases and then present how we applied genomic knowledge. First will be the clinical diagnosis. A patient came with suspected senior loken syndrome, and he had basically renal related problems and renal failure, underwent renal transplantation at 11 years of age, and subsequently once again second renal transplant when he was 23 years old. He had a brother who died with renal disease, okay, and then he started to develop ocular problems, night blindness and so on at a later age. So the physician referred the patient suspecting it might be senior loken syndrome when he was 31 years old. So that's the pedigree, and one of his sister passed away with renal failure. The other brother is all right. The third is himself, who's the patient who came to us. So doing a pre-test counseling, we did a genetic test in the patient, and then we found that there was a mutation which causes, as you can see here, I'll keep my talk as lay as possible, a gene called TTC21B, which causes nephrolithiasis 12, which is an autosomal recessive condition. So that was the mutation. There were 2 exons, so it was a compound heterozygote mutation, and both were pathogenic, and that's the reason he got it at a very early age. But there was a problem with the diagnosis. It was not senior loken, it was nephrolithiasis 12. So that's the benefit you get when you do a genetic test, when you do a genetic test in these patients. The diagnosis can become much more accurate and molecular in nature. So nephrolithiasis is a condition which is a ciliopathy. It affects literally every part of the body which has cilia, including the eye, and therefore they get retinitis pigmentosa and they gradually lose vision. So we counsel the patient about all this, and the marital options were also discussed with the individual. Now the second situation is where you actually have premarital genetic counseling. A patient came with Usher syndrome, that's a pedigree, and for many over here, consanguinity is a bit common in southern India, and you can see that these double lines where people get married with first cousins or uncle-niece marriage, that is sort of reducing in the current situation. So in this family, the first girl had Usher syndrome, and they were a twin who were not affected, and she was a graduate at that point of time, somewhere in the middle of 20s as far as her age is concerned, and therefore wanted to know whether her children will be affected. And that is the main thing on which she wanted to decide whether to get married or not. So with the pedigree in Usher syndrome, where they have vision problem as well as hearing, you can quite confidently say that it won't be recurring again provided she marries somebody outside the family, because it is an autosomal recessive condition. But nevertheless, being a graduate and with vision and hearing problems, she put her foot down and said that I want a genetic test to be done, and therefore to be very confirmatory. And we did the genetic test, and it's a gene called as GP9, and we found a pathogenic mutation in USH type 2C. So therefore we said, look, this is a homozygous condition, and therefore both the alleles came from one of her parent because they were consanguineous, and therefore it resulted in this. As far as you get married outside the family, nobody in your next generation will be affected. That gave her a confidence, and she left our counseling session. I don't know after which she got married or not, okay? Right, so that's a benefit with which we apply it in India, where people who reach around 20s and 30s, the parents are very keen to get them arranged for a marriage. The third situation was preconceptional and prenatal put together. The patient was a long-term patient of mine, and he came to me at a very young age, and I've been following him up until 37 years old when he decided to get married. And we did, of course, I'm not an ophthalmologist, so you can all understand the fundus image better than me. So that's the pedigree, and he got married to somebody in North India. He's from South India. There's a reason why I'm saying that. And they wanted to plan for the family, okay, so for the child. So we screened the proband, and he had an ABCA4 compound heterozygote pathogenic mutation, okay. I'm not describing the mutation because that would be too much for this audience. So it was very clear that these two variants, DNA variants, were causing the disease in the individual, and therefore we said that if you marry somebody outside the family, you will not get the disease in the next generation. Accordingly, he married somebody from northern India, he being from southern India. And we had to screen her, and to our surprise, we found that she had a likely pathogenic mutation, which was quite a surprise and learning curve for us. And therefore, it was a very difficult situation, okay. If you go by the pedigree, you would straight away say that you go ahead with the marriage and plan for the next child because it is autosomal recessive, and your wife is far away from your place, and she's in no way connected by caste or community with you. But then when it's a very large gene, and therefore she had a likely pathogenic. Now the situation was, which we explained to the family, is that any one of these alleles from the father, if the child inherits, it's pathogenic. And in the mother, she had one allele, which is wild type normal, and then the other one was likely pathogenic allele. So the more important is which allele the fetus picks. If the fetus picks the likely pathogenic allele, the child will be affected. Whereas if it picks the wild type, it won't be affected. So we were equally tensed about this outcome as the parents were. So at 15 weeks, we did a prenatal test. Okay, all these studies are ethically approved by our IRB. And when we tested, this is what happened. The fetus was quite smart. It picked one pathogenic allele from the father and the wild type normal allele from the mother. And therefore, and 15 weeks, we could tell that this fetus, after it's born, will not get Stargardt disease. So that's the power and accuracy of doing a genetic test and helping your patients with the genomic knowledge that we have gained in the past 30 years. Now, let me come to the last situation where people are more interested. We have more patients coming in this group, finding out information about therapy by interventions and research. There are about more than 3 dozen genes, retinal degeneration genes, which are under therapy now. RP65 gene has come into practice, but it's a bomb as far as the expense is concerned. But hopefully these things will become cheaper by the day. So I'm going to talk about one patient who had Usher syndrome, okay, another patient who had retinitis pigmentosa, but did not actually have hearing issue. Okay, this is not uncommon in Usher syndrome. So I'm saying Usher syndrome because of the reason that we screened his genes. Of course, these are other findings of his as well as his daughter. So that's a pedigree, and there were 3 alleles in the family, and some of them were a variant of unknown significance. Is the biggest headache that we have in genetic counseling. And we presume that 2 of these alleles are causing the disease. So the father and the daughter have the problem. So they are very keen about therapy. And the reason is that there are about more than a dozen genes causing Usher syndrome. And therefore, doing a genetic screening is quite complicated, and not coming across VUS is something you have to be lucky with in genetic counseling. So Usher syndrome gene is sort of a ciliary gene which has a pathological effect on the photoreceptor as well as the organ of corti in the ear. Now, there are many therapies coming, okay, like gene therapy, and then you have cell therapy, the stem cell therapy, and then RNA interventions. So RNA editing more than gene editing is picking up more faster, and therefore we do tell all this information. Hopefully in less than a decade we'll have all these therapies in practice in retinal degenerative conditions. So the future is, as you can see in the slide, that in a conventional way a patient comes with congenital cataract to your clinic, pediatric clinic, after birth, and then you do all necessary interventions, but then over a period of time you see if it is dystrophic or so, and finally you make a diagnosis. It's 3 years because all the signs, symptoms slowly start to appear, and then you know it's a syndrome. Whereas today we do gene screening and we know what is the gene, and then we can know the mutation, and then slowly as a clinician you start to observe the signs and symptoms, and you can prepare the family for rehabilitation and so on, depending on what kind of syndrome it is. Okay, so that's the way it is going, and you can do all this today in India, every major city. It's slightly expensive to do this test. The test by itself costs about 10,000 rupees. The different kind of genetic test, exome sequencing is the most common that we do for our patients. So therefore, there are 4 situations, as I told: clinical diagnosis, premarital genetic counseling, preconceptional, prenatal, and interventional research reasons for which all your patients come. So if your patients are coming to your clinic, please remember that there are many things that you can do to help them, okay? Not even though there's no currently good treatment available. So that's the summary of my talk. I spoke about a couple of situations, okay? I gave you some of the good situations, but there were bad situations where the fetus did pick up the wrong allele, okay? I didn't show them all, so it's not fairy tale all the time, okay? So with that, this is the Bangalore group I'm associated with, Narayan Netralia, and you can see that this is a clinicians group, and then this is the laboratory personnel group in Bangalore, a very vibrant group publishing and doing clinical services in Bangalore with 4 different centers in that major city. And of course, I am connected with other institutions as well, and this is the one in Chennai. And then I have 3 ophthalmologists doing PhD, and Pratibha is sitting here in this audience. And there are a few MSc students who are doing PhD with Maastricht University in Netherlands, okay, as outreach program. And Rajeshwari is doing her, going to register herself for PhD. With that, I come to the end of my talk.